Hey, hello and welcome to Deafblind Information Australia's webinar today, Deafblindness in Children with Complex Disability. We have two guest presenters who will be sharing this topic with you. Emily Trustwell will start the presentation. She's an occupational therapist who is passionate about improving access and quality of life for children with complex disability. She has a deep interest in deafblindness and holds a Masters of Disability Studies in Sensory Disability. Rachel Tomic, our second presenter, is a physiotherapist with a special interest in early intervention, complex disability and vision impairment. Rachel holds a Masters in Advanced Paediatric Physiotherapy Practice, and both Emily and Rachel have worked as deafblind consultants and now run a private practice. So I will hand it over to Emily for acknowledgement of country and then to start the webinar.
Okay. Hi, everyone. I'm Emily. As Melanie said, I'm an occupational therapist and passionate about working with children with complex disability. This includes working with children who are medically complex, have rare diagnoses, and who are deafblind. I have completed further studies into deafblindness and hold a Master of Disability Studies in Sensory Disability.
And my name's Rachel, and as Melanie said, I'm a physio and I work with kids with complex disability and love finding creative ways to support their unique needs, which usually almost always includes sensory disability. Our caseload at Kinetic Kids consists of children as young as 3 months old through to school age who have complex needs. We love working with children and their families to navigate this path less travelled. So before we begin, we wish to acknowledge the traditional custodians of the land we're presenting on, the Whadjuk people and ongoing cultures of the First Nations people across Australia. So today, Emily and myself are located in Booragoon, which is the Indigenous name given to the suburb in the early 1950s. Booragoon is a name for the lower reaches of the Canning River, and it was once a suburb surrounded by many Aboriginal biddy or paths. These biddy connected major campsites and places where favourite foods and resources could be collected. Nowadays, these biddy are major roads or highways that connect Perth.
Emily again. In today's presentation, we're going to discuss complex disability and rare disease, giving an overview of both of these diagnoses and what it means for the kids that we work with. We're going to discuss the F words of childhood disability, a profound research article that has shaped how we work. We will give a brief overview of brain anatomy, of cerebral palsy and rare disease, so that we can discuss the impact on vision and hearing. Following this, we will discuss the evidence available to support intervention, some assessment tools, and then tie it all together with a case study at the end.
Hey everybody, it's Rachel again. So this is the ICF. I'm not sure if many people are familiar with it, but it's a way that we use to describe disability as more than just a label. It helps us to balance out the diagnosis and the information that makes each child unique, highlighting priority areas for children and family. Childhood disabilities are complex conditions that can impact the trajectory of childhood development into adulthood. So usually we have at the top the health condition of the individual and all the other domains underneath can impact the child's life and how they function. So we have our body structure and function, which used to be the centre of how we treated disability. However, we're moving away from the body structure and function and thinking more about activity, and participation, environmental factors, and personal factors. So the things that make children unique and more fun for them.
Cerebral palsy is a complex heterogeneous condition, which means that every person who has a diagnosis of cerebral palsy presents differently. The term cerebral palsy is an umbrella term which defines a group of conditions with varying presentations and severity levels. Cerebral palsy is the most common disability of childhood, which occurs because of a lesion or maldevelopment in the developing brain. Children who have cerebral palsy may have associated vision or hearing impairments, depending on the structures in the brain that are affected by the brain injury.
Rare diseases are life-threatening or debilitating. Statistically rare are less than 1 in 2,000 people. They are complex, and approximately 5,000 to 8,000 known rare diseases have been identified. Most of them have a genetic origin, and there are a few things that they have in common. So usually a rare disease has no cure, cannot be prevented, and has a genetic origin. In our experience, although there are a few different rare diseases, they generally present with similar impairments.
We can group together cerebral palsy and rare disease under the umbrella of multiple and complex disability due to the cumulative impact of multiple diagnoses on the individual's functioning. These kids need special supports in place who have a deep understanding of the impact of each of these presentations on one another and the impact this has on the child and their family. So we know that cognitive and sensory impairments with functional limitations often co-occur. Some other common things that we see that come along with cerebral palsy and rare disease is pain, epilepsy, intellectual disability, musculoskeletal deformities, behavioural disorders, sleep disorders, vision and hearing disorders, and speech difficulties. These children have not just motor impairments, but they can also have all of these other conditions. Each of these diagnoses needs to be considered, assessed, and understood by the professionals working with the child so their overall function can be totally understood. And then that needs to be concisely explained to the parents. Research shows us that approximately 1 in 10 children with cerebral palsy have severe vision impairment and blindness. It is estimated that up to 70% of children with cerebral palsy have cortical vision impairment. However, as the understanding of CVI, cortical vision impairment, is still emerging in the community, this is still an estimated figure. Further understanding about CVI and cerebral palsy is needed to ensure all professionals working with children with cerebral palsy are able to identify red flags and refer on for appropriate testing. CVI is often not diagnosed in children younger than 2. However, it's still recommended that interventions are targeted toward at-risk individuals to ensure the kids who need this level of support aren't missed. Okay. We're now going to discuss the F words of childhood disability. On the slide, there's a picture of the ICF model that Rachel talked through earlier, but there's some different words on the model this time. So we've got body structure and function with a label of fitness and a kid in a cute little bike. We've got activity, also known as functioning, and a picture of a child playing. We've got participation and friends with a picture of some little kids playing together. We've got environmental factors or family and a picture of a family there. Personal factors or fun. And there's a little girl in a wheelchair dressed up as a fairy. And the word at the bottom is future with an arrow pointing across the screen. The original article that discussed the F words of childhood disability is called The F Words of Childhood Disability. I swear this is how we should all think. And this was published by Professor Rosenbaum and the team at CanChild. This article and then the framework has been transformative in shaping a reform in the use of the ICF for children. The F words were proposed to further develop the ICF model, taking away the idea of fixing an individual and their impairments to ensuring interventions are strengths-based and client-focused. This is a fantastic framework to use when working with children and their families to establish real-world therapy and education goals, which focus on what's really important to kids. These include functioning, which refers to what people do. How things are done is not as important. For children, this is usually play, whatever play looks like for that child. We've got family, which represents the essential environment of all children and youth. Family-centered practice results in identifying collective client-centered goals and improved therapy outcomes. So for us, that includes including the family and everything that we can. And friends refers to the friendships established with other kids.
Hey everyone, Rachel again. We then have fitness, which refers to physical and mental well-being. So the fitness for the individual can be at the level that is appropriate for them. So it might look different for somebody that is a wheelchair user versus somebody that has mobility in other ways, such as a walking frame. Fun includes activities that people enjoy. And future is what life is all about. So using this idea, we can see that domains are interrelated, and focusing on a domain such as friends can lead to improvements in other domains. So if we focus on friends, we can think we're having fun playing a game together outside on the playground, which will then impact our fitness, our functioning, and our friends and our fun. And then also our family, because our families are coming together. All of this will then have a good impact on our future development.
It's Emily again. So now I'm going to briefly talk about brain anatomy and cortical vision impairment. So I will refer to it as CVI. CVI is a condition where no two individuals are the same. There have been MRIs and particular lesion locations on the brain that can predict that someone may have CVI, but a brain scan can't conclude how severe that vision impairment is going to be. There's a fantastic webinar available about CVI on the Deafblind Information Australia website under the About Deafblindness tab that goes into this in greater detail. But we just wanted to flag here that lots of the kids that we work with present with complex physical and medical needs, and often their vision is not number one priority, or it's not the first thing that gets flagged by families. And as health professionals working in early intervention, we have a really important role in having a deep understanding of what CVI looks like, what auditory processing disorder looks like, and what deafblindness can present like in children who have profound intellectual disability or who may be nonverbal, to see what appropriate adaptations we can make for them to support them to meet their early intervention goals. So that's why we flagged this here to go and do some more research.
It's Rachel again. So now we're going to talk a little bit about evidence-based practice and the literature. So As we mentioned before, we work with a lot of young children, many as young as 3 months old. And to ensure we are offering the families with the best support we can, we use a few key articles. One of these are the International Clinical Practice Guidelines for early intervention for children aged 0 to 2 years with high risk or diagnosis of cerebral palsy. So, Morgan et al. Have developed guidelines for children to help with a whole variety of domains, including motor, cognitive, communication, eating, drinking, vision, sleep, tone, musculoskeletal, mental health, and parenting. As we said before, for many of our children, we don't just see motor impairments, and this is once again reflected in this article. In reference to the visual domain, the guidelines state that we suggest surgical correction of strabismus coupled with making sure that the individual has good alignment so they can function in their everyday tasks. Visual chaining. So early visual training is recommended to improve visual function and attention to stimuli, and colour contrast.
Use of the developmental journal for babies and children with visual impairment can be a really good resource that we can use in early intervention to track development over time with specific activity ideas about how to support families. In the early intervention space, particularly for complex disability, there are a limit of evidence-based tools available for clinicians. However, when you do the digging, you can find resources that you can adapt to for what you need. So the CVI resources developed by Roman Lancy are widely available, and many have been translated into easy read tools for families to use. Some of their research has been criticised for its lack of thorough research and single study case design. However, the tools are still widely used. And in my opinion, if it picks up someone who has CVI who might otherwise have been missed, then it's a good tool and it's done its job. Work is being done to create new synthesized definition of CVI and practice guidelines. And there's some courses available on the Next Sense website, which might be a helpful tool for people who are wanting to learn more. There's been lots of people who have done lots of research on CVI, and there's lots of resources available simply on Pinterest, on Google. Then obviously not high level peer-reviewed research articles, but if we're just building an awareness in the community of what's going on for our kids, then I think that that's a fantastic thing. Something that we are always keeping an eye out for is diagnostic overshadowing, which diagnostic overshadowing means somebody's diagnosis is being used as the reason behind all of the behaviours that we're seeing of that child. So, for example, a child with a diagnosis of cerebral palsy and intellectual disability not visually attending to a toy or not responding when somebody comes into their space, those behaviours being assumed to be because they have a diagnosis of cerebral palsy, whereas we have sometimes seen that those diagnoses are there for the kid, but there may also be underlying vision and hearing things that haven't been thoroughly assessed or understood, and that we could do something about their vision and hearing to help them participate more in school or at home or on the playground or whatever that might look like. So we're always really strongly advocating for our kids to be screened for vision impairment, for hearing impairment, or for CVI.
All right, Rachel again. So now we're moving into our case study, Hannah. You can see a picture of Hannah on the screen. Hannah, Emily and I have been working with each other now for a number of years. On the screen, there's a photo of Hannah sitting in her chair with her dog, Daisy. Hannah is a cheeky 5-year-old girl who lives with her family in Perth. She absolutely loves watching the Wiggles, playing with musical toys, cuddling her family, and swimming. Hannah has a diagnosis of complex and multiple disabilities, and this includes trisomy 21, ABI/cerebral palsy, centralized sleep disturbance, epilepsy, CVI, auditory processing disorder, cardiac disease, hypothyroidism, and global developmental delay.
It's Emily again. So here we have used the F-Words model to get a really thorough understanding of Hannah. So on the slide, you can see the F-Words model has been put up there. It looks a little bit different to how it did in the previous slide. So when looking at Hannah, on paper, she presents as a really complex little girl. There's lots going on for her. And walking into a case like that, you can often feel quite overwhelmed because you don't really know where to start. And it feels like all of the things are a priority all at once. So in order to kind of make a stepped plan that doesn't feel overwhelming for the health professionals involved or for the family, we need to take this big picture view of the child and have a look at all of the different domains that are present in her life to get this really thorough understanding. Hannah is a child that when we first started working with her, she didn't have a diagnosis of CVI and she didn't have a diagnosis of auditory processing disorder. They're two diagnoses that after working with her for a while and having done some thorough assessments, we advocated back to the medical team for them to review her vision skills and her hearing skills because it just felt like there was something that wasn't quite happening for her that was impacting on her development. So the only reason we went back to the medical team was because we felt that what we were doing as early intervention professionals wasn't quite getting there, and we just wanted to have a thorough understanding of, is there something else impacting on her function that we don't know about yet? So let's talk about Hannah. So if we look at the fun domain for her, the things that make her really happy that she loves doing is listening to music and dancing. A particular favorite is the Wiggles and Emma Wiggle. She definitely has strong preferences about what her favorite songs are, and she will let you know if she doesn't like the song that's playing. She has some toys that she really enjoys interacting with, which include some Switch adapted toys and some toys with extra lighting in them. We started using Switch toys and adapted toys after we found out about her CVI, and we noticed a significant increase in engagement in play when the toys we presented to her fit within her visual range. She enjoys playing with her big brother, who loves roughhousing her, and it's the greatest thing to see. And she also has a few games that she enjoys playing on her iPad, a lot of which are adapted games. So she has strong connections with her family. She lives with her mum, dad, her big brother, 2 dogs, and lots of birds. Rachel and I are both terrified of birds. Anyway, she's got connections with her grandparents and her extended family. And we've done lots of work to empower her family to get the support that they need so that they can remain really strong pillars in Hannah's life. For fitness, Hannah enjoys dancing, she can get up in her walking frame and walk around the house with some support with music on, and she loves to wiggle around. Rach, do you want to jump in here?
And for fitness, Hannah loves dancing, as Emily said. So we will often use her walking frame as a supportive way for her to participate in independent standing and dancing along to her favourite songs. Hydrotherapy. Hannah recently was the lucky, what's the word? Recipient of a spa through a telethon grant. And we've been doing some really amazing hydrotherapy and swimming in her pool, which she absolutely loves. Bike riding on a adapted bike that we obtained for her. Walking in her walker and play. So as we mentioned before, all of these domains are interlinked. So we will often use some of her Switch adapted toys and her fun items in her fitness domain because we know that that's what motivates her to participate and engage in activities. Functioning. So the things that are important to Hannah is play, sitting, reaching, communicating with those around her, moving around independently, and learning. So once again, all that Emily and I do, we have these ideas in the back of our mind. And then friends. So her family, her brother, and her cousins are the people that are the most important people in her life.
It's Emily again. Okay, so we're now going to talk about a goal that we set for Hannah with her family and how we use the F words to guide goal-directed therapy intervention for Hannah, considering her sensory disability. So the goal that we set was for Hannah to independently eat a tub of yogurt using adapted cutlery in her home environment. Yogurt is probably her favourite food, second to chocolate pudding. And so it's a very strong motivator for her. She also eats yogurt frequently, so it's something that we can practice often. And it's an activity that she enjoys. So this goal is a family-specific goal, which they have identified and are motivated to achieve. So we've got the buy-in from everybody in Hannah's system to achieve this goal. We have been working on this goal in a number of ways, considering Hannah's complex needs. So before we can jump in and start working on this goal, we need to consider all of the health-related aspects of this task, as well as the safety aspects, the positioning aspects altogether. So Hannah had a dietitian involved to review her overall nutrition to make sure she was hitting all of her nutritional targets that she needs for a kid of her age. Hannah's speech pathologist reviewed her swallowing and established a mealtime management plan so that we were sure that the activity of eating a tub of yogurt is something that she can safely do, considering her dysphagia. We had input from physio to look at positioning needs. So Hannah sits in a supported seat, and we needed to make sure that she had appropriate head control and trunk control to be able to participate in the task. And then as the OT, my role is task-specific intervention, which includes building on her hand skills and visual motor processing skills. So this looks like doing lots of play with different textured things in Hannah's hands because she has a history of lots of pain related to strange adults touching her hands. We had to do lots of things to build her sense of trust in adults again, that when you touch my hands, it's not going to hurt. And then that has been building up slowly over time to her holding a spoon in her hand. We've also looked at different kinds of adapted cutlery to compensate for her motor skills. And some of these spoons have had lights or different colours. And we've just been experimenting with what will work the best for Hannah's CVI. So working towards this goal has included lots of different things. We have done some play with switches to work on functional reaching. We've done lots of messy, very messy play with craft activities, some painting, sensory play with different textures to develop her reaching skills, her grasping skills, her ability to pick something up and then move it to another place, and her ability to voluntarily release an object. These are all things that are needed to be able to bring a spoon to your mouth with yogurt on it and then eat it. We have considered her sensory needs in this task. So we looked at reducing the background noise in the house because she has auditory processing needs, which mean that when things are too noisy, she just can't take anything in. We have used CVI positioning boards, which look like, I think it was just a big fridge box that we spray painted black to just kind of block out the rest of the house so that she didn't have to take in too much visual information while we were focusing on the task of eating yogurt. We got a black tray for her feeding chair to reduce the visual clutter that she had to deal with. And as we said before, the use of contrasting or light up spoons to support the activity. And luckily yogurt is white, so against a black tray, it naturally has high contrast built into it. Specific development of her skills have included forward and backward chaining of the task. So forward chaining is she does the first part of the task and I finish it off for her. And backward chaining is I do the first part and she does the last part. So I might put the yogurt onto the spoon and then pass her the spoon and she gets the spoon to her mouth. And then she might bring the spoon out of her mouth, give it back to me, and then I put the yogurt on. Eventually we'll build that up to her getting the yogurt out. But for now, that's a really good micro goal achievement. We have also used hand under hand support as she's tolerated it, and easy hold. So these things that can hold the spoon to her hand as appropriate for her. So Hannah can now bring a preloaded spoon of yogurt or custard from about 15 centimetres away from her mouth into her mouth, clear the spoon and bring it out of her mouth with support just under her elbow. Hannah has lots of support workers who help her through her day. And so to support these people to get to know her best, we completed an individual communication handbook all about Hannah. This tool is available on the Deafblind Information website, and it was really useful for Hannah's new staff to get to know her really quickly so that they can have a full picture of everything that goes on in her life. And yeah, they can be brought up to speed really quickly. Cool. We've zoomed through our content super quick.
I think that's, oh, sorry. Sorry, that was my fault.
Get out of it.
Red's Rachel back here. That's pretty much it, I think. And it's more just about remembering to consider all elements of the child, like we have kind of tried to drum into this presentation. While you're working on a goal, you need to be thinking about the individual as a whole, really. But I think that leads us to our thank you and our question time.